Friends, welcome back to the Death with Dignity podcast. My name is Andrew Flack, and I'll be your host. Dr. Tom Cummings is formerly a family physician in Pacific Beach and now working as the medical director for Interim Gift of Hospice. Having been involved in over 200 end-of-life experiences, Dr. Cummings discusses the evolution of death with dignity while identifying barriers and obstacles that still exist today, and why he feels the End-of-Life Option Act is a necessity for terminally ill patients. As always, we appreciate your time, we appreciate your comments, and we hope you enjoy the episode. All right, cool. Well, welcome, everybody. Welcome back. Thanks for listening. I'm Andrew Flack, and today we're here with Dr. Tom Cummings. Dr. Tom, introduce yourselves to the listeners and tell us a little bit about yourself and just your general background of who you are and maybe your educational experience and how you're involved in this field.
Okay. Well, I'm a native San Diegan, proudly. My dad was in the Navy. So anyway, then I went to high school here, went to college at Stanford, UCSD Medical School. And when I was an undergraduate, I studied psychology, which kind of made me interested in people's approach to their health, such that when I went to med school, I decided to become a family doctor just because it puts you in touch with all that's going on, and then also the family dynamics, taking care of third and fourth generations of families, so that was fun.
That's cool.
And then early on in my experience, firstly, I lost my dad in a commercial airlines crash the week before I started medical school. And that kind of put me in touch with grief and dying. And then Doris Howell was a professor of mine in medical school, and she was teaching a class on death and dying. We used Kubler-Ross's book as a text, and so that kind of put me in touch with the grief process and respecting people at the end of life. And so during my practice, I was very focused on making sure that as people transitioned, that they were as comfortable as they could be and try to avoid unnecessary intervention. And then the San Diego Hospice was founded early in my practice, and I became a physician that would take care of hospice patients, so that if they had somebody whose primary care doctor wasn't interested in following them, a lot of physicians felt as people were dying, there's not much I can do. There's nothing more I can do to reverse the course of this illness, so they would kind of back away.
And tell us a little bit, if you don't mind, about hospice care and what exactly that entails.
Hospice care is, by definition, it's somebody has 6 months or less to live suffering from terminal illness. That is what Medicare requires in terms of qualification for the hospice benefit. In our model, we take care of people in their homes or in nursing homes. We don't have an inpatient hospice. There is such a thing as inpatient hospice. San Diego Hospice used to have one up close to the UCSD Hillcrest campus. But it's basically assuring comfort in transition and helping families cope. We have social workers that get involved. You have the option of having a chaplain involved if there's a sense of wanting to explore some spirituality as you come close along with your family. And then nurse will see the patient at least once a week. Nurses' aides will come and help bathe and take care of the patient, change sheets, things like that. We have volunteers that are available to provide respite care if a family member needs to run to the grocery store or however it might work. So basically, it's trying to help to keep people in the home prior to death. Most ideally, then death occurs in the home, in the comfort of the home, and that we make an effort to keep people out of the hospital.
Absolutely. That's got to be some of the hardest work to do on this planet, and in my book. And I'm just thinking of your experiences as an individual, and you mentioned in particular how your father passed, and that was obviously a very sudden tragedy in your life. Do you feel that that incident was almost a driving force behind you kind of following this path in regards to hospice care? And
I mean, it definitely was instrumental. I don't know if it was absolute. I recall as an intern, I was losing a patient who was around my dad's age. It was a woman. She had multiple kids. And just experiencing that vicariously with that family was a pretty big flashback for me. And then it caused me to think, how could we do this better? You know, she was in the hospital, and that happened a couple times in training where families would be around young families as their parent was dying. And then I'd think, well, at least they got to say goodbye. But apart from that, how can I learn from this? How can I help in this regard? Perhaps similar to you, Andrew, saying, how can I cause my experience to help others who might be in a similar situation?
Sure.
So for me, it wasn't so much the patients as it was their families.
Right.
Because in death, it's kind of who we leave behind that is suffering. I don't believe that there's suffering after death for the individual who's passed on.
I agree. And that's for me, and this whole process, I know, is something that I always had the most difficult time with. I wasn't, when considering my own circumstances, always afraid of transitioning and passing on. What I was always most afraid of is what would happen to the people I left behind. And it took me a long time to kind of process through and then realize that the people I'm leaving behind are just as strong as I am for, going through what I'm going through and being there right along the way with me and supporting and being there. And I think that, of course, there's the grieving stages and you need to feel that out, but they'll be just fine in the end. And it gives you a lot more comfort when you recognize that. So I feel like I'm finally at a place for myself personally where it's okay to be able to let go when that time comes. So it is, it's important to think about those people and the caregiver role, especially in those individuals, to stop and consider them. When considering your job and your line of work, what do you find the most difficult and challenging parts? And then what do you find as more rewarding and positive and beneficial?
Well, the difficult parts are just watching people suffer. And there are people who have pain that's refractory to, a heavy armamentarium of drugs.
Yeah.
And so then, I kind of scratch my head and say, I really want this person to be comfortable. I speak to our patients a lot, and I say we can do our best to keep you pain-free and to mitigate your anxiety, mitigate your suffering, help your families to support you. But then there are times when it seems like an exercise in futility.
Oh.
And then it's like, okay, what next? So, Just a couple of days ago, I visited an ALS patient in Chula Vista who was at that point, and I just said, we just have to go back to start and see what we can do to figure this out so I can put you on a drug regimen that will at least assure your comfort and mitigate your anxiety. So that, I think, is the biggest challenge.
Yeah.
And then the reward is if you are successful at that. And then apart from that, a lot of patients and their families are grateful. And, that to have that gratitude expressed is good for me.
Yeah.
And that apart from that, then knowing that I did my best to ease their transition, which is what I regard my role, easing transition into whatever's next. And anyway, that offers me a certain sense of pride and giving back.
Absolutely, and you should take pride in that. This is, as mentioned earlier, an extremely fragile and difficult job that you're doing. I mean, it's humanity at their most vulnerable point. So I give you a tremendous amount of credit. And that kind of leads us in a way to the, I guess, concept and idea of death with dignity, and also the End of Life Option Act, which is in California a law that allows a person with a terminal illness to use a medication that will end their life in a humane and dignified manner. And this is something that I am eligible to use as a patient and an individual with a terminal disease. And naturally, you working in this field, I'm sure, have quite a bit of experience with. I was wondering if you'd speak a little bit to the End of Life Option Act and how that intertwines with your organization.
Well, let me backtrack.
Sure.
To my career path.
Please do.
And basically, then I was a family doctor in Pacific Beach for a little over 20 years, and I helped people transition with the resources that were available to us then, which was hospice care at home, pain medicines, anti-anxiety medicines. I took care of a lot of HIV positive individuals early on in that.
Right, because that was...
Right, and so that was, from my perspective, those deaths were very problematic. I was present 2 or 3 times in the home when these people would pass, and they were generally young and healthy individuals, other than their HIV, which was causing, central nervous system lymphoma or something that was then taking their life. But their hearts were strong, their lungs were strong. Whatever was going on in their brainstem to drive the next respiration was strong. And meanwhile, they were obviously suffering. And thereby, too, their loved ones who were in attendance were suffering. And we would wait and wait, and then finally someone would take their last breath, and I would think, gee, I sure wish there was some other way to deal with this. I mean, we've had dogs that we've taken to the vet when they're at the end of their life, and it's just a quick euthanasia with the euthanol, and I just thought it sure would be nice if we could have that in our armamentarium, but we didn't. So over the course of my career, after I left practice, and part of it was burnout in...
And about what time was that? Was that like 80s or
no,
so?
It was in the early 80s that I was taking care of the HIV patients, and then I finally retired from my clinical practice in 2002 after 22 years of being the people's doctor of Pacific Beach.
Okay.
And anyway, part of it was that I was losing... I counted when I left practice, I had attended in death 250 people. Wow. That I could recall their name, their diagnosis, their age, it was succinct recollection. And the difference with that was a lot of them had been with me for 20 years or however many it was until they passed, and we had relationships.
Sure. Wow.
So I was not only
heavy.
losing patients, but seemingly losing friends. And I just said, I had a guy come in who would have been about my dad's age. Had my dad lived, he was dying of prostate cancer. We were buddies. And, I had to tell him this was it. And I just kind of broke down.
Yeah.
And, I just said, I think it's time for me to move on. I've seemingly lost some objectivity here. So I left my practice. I continued to be involved in other activities, and then kept my license current. Then the End of Life Option Act became law. And a friend of mine, Donna Olson, who had started the Interim Hospice, Gift of Hospice in San Diego, was very interested in providing this option to patients. She had worked at the San Diego Hospice as a nurse in the inpatient side. And her medical director at the time thought that this was contrary to the Hippocratic Oath. So he said, I'm leaving if this is what you want to do. So then she reached out to me, and I said, this is something that I'd like to participate in. It's something that I felt was missing in my years of clinical practice, and I'd be happy to come on board and serve in this role. So basically, End of Life Option Act brought me out of retirement. And what the End of Life Option Act is then is, as you say, providing a death with dignity, or allowing people the option to take a fatal overdose of a medication if they feel that their suffering is no longer tolerable. And in my mind, that's their call. So since 2017, then, when the law went into effect, I've been writing the prescriptions.
Okay.
I did have a brief break when I had to have my ankle fused, but now I'm back.
Excellent.
So
Good. That's we need advocates like you supporting individuals who feel that this is an option for them, or should be an option. And you mentioned the Hippocratic Oath and how that is a barrier at times for some doctors and individuals. And I wondered if there were other barriers that you found in your experiences with whether it's doctors in the medical profession or even patients who don't find that as a reasonable choice.
Well, the main barrier, I think, in people's minds as patients would be religious, such that how they were raised religiously causes them to feel that their fate is in God's hands. And regardless of their ability to intervene, perhaps as a gift of God, that they do not want to quote unquote, commit suicide, that it's a sin. So, I've had this discussion with patients and their families, and Dolores Huerta, who's one of the founders of the United Farm Workers and is Catholic, has said this is something that we need. She's one of the big proponents of this effort through Compassion and Choices. So there are ways, I think, to rationalize use of this medicine and have it yet be compatible with your religious beliefs.
Sure.
Otherwise, there are physicians who have those similar religious beliefs, and what I say to them when I'm asking them to say perhaps to serve in the consulting role when I'm the attending physician writing the drug, I said, well, it's not your job to put your beliefs onto your patients. It's your job to support your patient
Sure.
in their beliefs. So all I'm asking you to do as a consultant is to say this person is able to make this decision. You're not necessarily agreeing with it.
Right. Right. That's reasonable in my opinion. Do you generally get any pushback in that situation? I feel like this topic it's either you're in or you're out. There's very little in between. So I can imagine it being tough to kind of try to sway someone's opinion if they are not in.
I mean, that is the case. And I have had physicians say, oh, I hadn't really thought of it that way. And, I'd like to help. I like this patient and I can see that they're suffering. I'd like to help them. It's not something I would do for myself, but I respect their decision and their values.
Good.
And my observation is that as we're doing more of this, or more people are opting for this, that those physicians are more coming on board. There are some circumstances where physicians are forbidden by contract from doing this if they work, for example, for a Catholic health system or any federally funded age system. Congress has enacted a law against paying monies to health centers that are federally funded that support what they call assisted suicide. So I have had physicians who say, oh, sure, I'll sign that document. And then their boss, the clinic director says, you can't do that. Wow. We're obligated by federal law to not participate.
That's fascinating. And talk to us about the difference between the idea of the End of Life Option Act and something like suicide. When I consider suicide and think about that process, to me, it is an individual who's generally likely depressed, suffering maybe from some kind of mental health disorder, does not want to live anymore, and makes a choice to leave this planet. Whereas somebody who is sick with a terminal disease, I would think that most of these people do want to live. However, they are just so sick and in so much pain and suffering. And again, we know this is a disease that's terminal. There's nothing more that the doctors or medical profession can do to cure them of this disease. So to make that decision to end their life in a humane and dignified manner, I support that, as I think, you get to a point with suffering where enough is enough. What is your perspective on the idea of death with dignity versus something like suicide?
I mean, I think you stated it well. And apart from that, it may be a matter of nomenclature or just what is the definition of suicide. And
certainly semantics are
right.
a component, absolutely.
And then there are people who hear that word and think negatively about it. I mean, in my experience, I did have patients that would commit suicide, and typically they were some form of psychological agony, not physical agony, although right. The two can be associated with one another. And then the other main difference is that they are generally alone.
Yeah, absolutely. That's
right. So whether it be the hanging, the gunshot wound, however you might choose to end your life, to have your loved ones find you subsequently. I mean, and that is a huge difference with medical aid in dying, is that this has been predetermined, it's been discussed, it's been accepted most generally. Families are present. People are having their final goodbyes, and then it's witnessed, and it's peaceful, and it's done.
And that's something that I think, as I explore this topic more and learn about it, that I find a positive and a benefit of this process. And when I think of my own path down the line, how lucky I will be if I am in that situation to be surrounded by the most important people in my life and the people I love and friends and family. Not everyone, a lot of people who pass, they aren't with those
Well,
individuals, and they
especially
might be
now in
alone.
COVID.
And absolutely with COVID and what we've experienced as of late, and just freak accidents and anything. I mean, none of this is a given. We know that, and to have that opportunity is, I think, a powerful thing for everybody involved,
Well,
including the people you leave behind.
I think it's most meaningful for those people. It gives them, a better sense of closure, perhaps, even though there are yet stages of grief that they'll have to go through.
Sure.
But
And what was that process like? It sounds like you've been with individuals who have used the medical aid and dying drugs. And can you speak to what that is like with their family, the whole process, consuming the medication to the passing of the individual? Just maybe some of those experiences.
I mean, most commonly when I've been present, it's been do this quickly. It's just like, okay, you're here. I've been waiting and I want to go forward with this. Then I will, I'll say, do you want to have some private time? I'm, a relative stranger to this family, or however it works. And then I can help to prepare the solution. It comes from the pharmacy as a powder, and then it needs to be mixed with water or juice. So then it's prepared, and then the patient has to be able to self-administer. So that's one of the requirements by law, is the patient needs to have cognitive awareness, full cognitive abilities, and then be able to self-ingest, whether it be to hold it and drink it from a cup, to drink it with a straw. We've had patients with ALS wherein they have a gastrostomy tube, and we can put the solution in a gravity bag, and then they can crimp it in their hand and release it. That's self-administration. There's the ability, I've had patients that have had esophageal cancer, or inability to swallow, bowel obstruction, whatever it be.
Sure.
You can have the medicine be administered rectally through a rectal tube, and the rectum absorbs drugs really well. So the same thing, a gravity bag with a crimp and then release, or a syringe with a plunger that the patient can then self-administer. So then what happens always is within about 5 minutes, the patient falls asleep. So they've said their goodbyes, they start to drift. I've had people say to me, "Oh, I'm feeling a little buzz," or
like feel pretty good, like
right.
like maybe euphoria, just
right,
a warm, good feeling,
then,
huh? Sure.
If you have some sense, yes, I'm on the threshold, and this is good.
Yeah.
So anyway, then it takes a while for the heart to stop and the breathing to stop. It's not the immediate effect like we experience with our pets in the veterinarian's office. But it's generally with the compounding formulation that we're using now, it takes about a half hour. And it can be longer, it can be shorter. I think the shortest I've witnessed personally is 10 minutes. Okay. Where somebody took their last breath.
Okay.
So the problem can arise with the more lengthy, terminal events, that the patient's families are worried that they're going to wake up.
Right.
And then what do we do? Will they have brain damage or however it might work? But thankfully, there's been enough experience with this that I don't think there's been a case where that's happened. They're clearly,
not from what I've read, yeah.
Right. And I've been I work with Compassion and Choices, and when I first started doing this, that's the group in Oregon that has been doing this for a sustained interval. Have lots of experience. Dr. David Grube. I have his cell phone number. If we're in a situation where I'm wondering, is this how it's supposed to work, I can call Dave and say, how, is this right? He said, yes. And I think in their experience in Oregon, when they were using Seconal, they had one case that was like 20 hours.
Okay.
But there's been a lot of studies done now on just fine-tuning the process and making a combination of drugs that is pretty much going to work for anybody, regardless of size, disease, metabolism.
Good. And it sounds like for the individual, it is peaceful and an easygoing transition. And the family, for the family as well, a peaceful opportunity to see them pass. Mm-hmm. And I think that's important on the way out, to see that there is a lack of suffering and that this drug really works and helps. It does what it's supposed to do.
Right. No, for sure. The first time I prescribed it, I had to be there.
Yeah, absolutely. Absolutely. Do you recall that first experience pretty vividly?
Yes.
Yeah.
And it was with the Seconal, and patients were dispensed 100 milligram, 100 milligram capsules of Seconal. And then the capsules needed to be opened, the powder emptied into a glass toothpick to clean it out and make sure you got it all. Mm-hmm. And so this was a little lady with metastatic lung cancer who was ready. So anyway, I think she weighed about 85 pounds. And so I'd mixed the medicine. I gave it to her. She started drinking it with a straw. And then about 3/4 of the way through, she fell asleep.
Oh, wow. So it was pretty potent stuff.
Right. And so then I'm thinking, do I need to somehow coax the rest of this into her?
Sure.
But I just know she has to take it herself.
Yep.
So I called Dave, and he said, don't worry. I think they said this is 40 times the fatal dose or whatever it might be.
Yeah,
and it's just so potent.
Yeah.
And that it would, kill an elephant.
Sure.
Or whatever that's worth as an analogy.
Yeah.
And then, she fell asleep. She took her last breath, and that was that. Mm-hmm. But I was happy to help her because she was angry that she couldn't do it sooner.
Oh, wow.
We had the 15-day waiting period. She was really suffering. When she came on our service, she was under the understanding that her disease was curable.
Oh, geez.
So, and that can be problematic too when people are given false hope and misinformation.
That's huge.
Anyway, when she knew that she wasn't going to survive and she felt so poorly, she just said, I need to do this ASAP.
Wow.
So.
Yeah, it's heavy stuff. And you talked about the type of medication that's used, and I'll never forget the first time. Well, I had gone through the process with my oncologist of completing the End-of-Life Option Act requirements, with meeting with the physicians and such, and the prescription was written, and I went for an appointment at UCSD, unrelated to the topic, just a general appointment, and they always print your aftercare report, and it has a list of your prescriptions on it, and I remember happened to glance at it, and I saw a bunch of new scripts on there that I had never seen before, and they were really odd medical type of words. I could barely pronounce them. Huge numbers, 30 grams of this, 30 grams of that, not milligrams, grams. Right. We're talking. I'm going, what the hell is this stuff? Then I'm reading the directions, consume this 1 hour before taking this and that, and do this and that. I realize this is a medication for the End of Life Option Act. And it just kind of hit you in that moment. Wow, this is very real. And it's something that is now on the table for sure. And I'll just never forget seeing that and the realization of how powerful and heavy this whole thing is, this whole process. But at the same time, knowing that that is there as an option is relieving, and it is a choice, and it brings a sense of comfort as you go through the disease.
Right. Well, I may have spoken with you about this before, but there are patients who just enjoy having it there for that sense of comfort, that where they are in their disease process presently, they're not considering it.
Sure.
But at some point in time, if they get to that point where, like in lung cancer, I'm gasping for breath or in so much pain, or it's nice to know that I will have something there that I can take. And I think the statistics are statewide for the number of prescriptions that have been written. About 67%, or roughly 2/3, are taken, but the others are at home. So having the prescription doesn't mandate that you take it.
Right.
You can yet let nature take its course.
Absolutely. And that is a great piece of the legislation, is that even if you do decide to call and have the medication delivered, you still don't have to necessarily follow through. You can decide it's not the right time for you. So I think it's important to, again, have that autonomy and that those options as a patient. And I wonder, when thinking about individuals and as they go through this process, really it goes back to me, the family and their experiences and how they are able to kind of respond and move forward after, their loved one departs. And just from your experience, how do families generally respond after their loved one passes? Do they feel almost like a sense of relief and calm and understanding, like, okay, good, this person is no longer suffering, and at least we got to see them go peacefully? There's got to be some comfort there that they can draw from.
I think so. I mean, it is relatively new in terms of our life's experience. And there are people who, and we had a chaplain that worked for us when I was last with Interim Hospice, who did our bereavement counseling. And she felt that it was perhaps different with people who had taken the end of life option, and whether it be more comforting or perhaps some guilt, perhaps, that I was part of this or whatever it might be. And she thought it would be worthy of study.
Oh, yeah. That would be a good study. So continue. Did she end up going with anything?
No, she ended up leaving our group, but I thought it was kind of a fascinating notion that it's different.
Yeah, exactly. How do families, long-term and short-term, how do they cope and grieve and move forward when, an individual does use that medication versus departing naturally, as you mentioned? Yeah, that's very fascinating. And one of the pieces recently with the End of Life Option Act passed, I believe back in February, they amended the bill and removed the 15-day waiting period, and it's now, I believe, a 48-hour waiting period.
That just was signed by the governor in October.
Right, yes, just recently.
That will then go into effect on January 1st.
Okay, good. And part of that, which I found interesting, is that hospice agencies are now required by law to state on their website basically their perspective on the End of Life Option Act. and whether or not they support and how they will provide services, or if they won't provide services.
Mm-hmm.
Do you think that will help, promote growth in this field in a way?
Well, there are people who are concerned that it there's not broad-based knowledge about this option, especially among, say, ethnic minorities or whatever it might be. But if you look at the demographics of the people who have used the drug to date, it's mostly white people.
Mm-hmm.
And so what does that mean in terms of access and availability?
Sure.
So that I think that that's one of the reasons why they included that language in the legislation. I think it should be a hospice's role to let people know when they come on service that this is an option.
Absolutely.
And then, yes, we can provide it for you, or no, we don't provide it, but we can help to refer you to someone who can help you with this. Or there are hospices that say, we can't have anything to do with this. We're a nonprofit. Our board of directors, has philosophical objections.
Right. Right. Yeah, I agree. It's important to be more forward with what this, offers to people. And
we will present it as an option, and people will say, "Oh, I didn't realize that was legal in California."
Exactly, and that's how my experience was. I didn't even know it was an option here, and this is well into my being sick, and it just kind of happened naturally. My conversation with my oncologist, how we kind of happened to get to that point, and then I look back, I think, I'm kind of surprised I didn't think about that initially in a way, because California is quite progressive, and yeah, I wouldn't have been very surprised to hear that, I suppose. But yeah, it's just not something you think about, as a patient, especially not early on in your diagnosis, and as things move forward. Yeah, it's hard to imagine that, I guess. But people need to advocate and share.
Right.
And, I mean, there are doctors who don't tell patients and who do their best to kind of hide it and sweep it under the rug and all that.
Well, and there was a recent article in the San Diego Union Tribune when they talked about SB 380, I believe it is, going into the legislative process, that the author's research indicated that people felt a sense of stigmatization in approaching, taking their own life, perhaps. And I read it, and I emailed the author. I said, I have never found that to be the case. I have experience.
Yeah.
And most commonly, people are content to know. But anyway, there is that aspect of it too, where, why should you feel stigmatized in doing something to end one's suffering? Just doesn't make sense to me. And I wrote a bit of a nasty communication to the editor, not for publication, but I just said I think this article was inadequately researched.
Good. And again, that's a way to advocate.
Right.
And yeah, I can't imagine. Well, I'd hope that there wouldn't be a stigma. And
that's something you would feel, Andrew.
Right, exactly.
Do you feel stigmatized?
No,
I feel stronger for perhaps having the courage to make this decision.
Sure, no, that's a good question. But for me, no, I don't consider it anywhere near the same kind of category as suicide. And that's just from my personal perspective. I know we all have differences, opinions, but from what I've experienced so far with this disease, we know that it's not fun having cancer or any sort of terminal disease. And I know that what I'm experiencing now, which has been hell as it is, is really nothing compared to what still lies ahead as the body deteriorates. And unfortunately, over the last few months, the body has been deteriorating. There's still a ways to go, I think. But
Well, and you make the call, and I can tell you when I suggested you guys come down to my house for this, as I started to think about it, I said, that's kind of selfish on my part. Andrew doesn't need to spend 2 hours in traffic.
well, that's kind of you. Thank you.
I said, gotta live for today.
Thank you for thinking of me that way, Tom. That is sweet of you. Very kind. And that's true. It is about enjoying each moment, and just something as simple as that. Yeah, a little extra time, it is meaningful. But I guess going back to the stigma, no, I don't feel that there's a stigma there. I wonder if I were to use that medication, or individuals who do post-mortem, you wonder. I think there's always a stigma. There will always be people who look at you and will say, yeah, he basically killed himself.
Well, nobody has to know. That's part of the law. They suggest that somebody else be there when you ingest the medicine, but it can be a hospice employee or whomever. You can do this medicine without letting your family know. That's your right as well. It's not considered suicide on the death certificate. The death certificate is indicative of your underlying disease. So your underlying disease took your life. You just decided to cause it to happen a little sooner than it might have happened otherwise. I did have a fireman who was very concerned as he was about to ingest this medicine that his wife would not get his his life insurance benefit and continued pension benefit, things like that, which it's written not to be paid for suicide. I said, your wife and you and me are the only people that know this. Death certificate will not reflect it, so that in that regard, post-mortem, feel free to have a clear conscience.
Yeah, right, yeah.
And apart from that, know that you have the right to tell people, I don't want you to say this, to tell anyone about this, whether they do or not. Perhaps you'll know.
Sure.
And then beyond that, I'll just say, who cares what other people think? Because I'm doing the right thing.
Hey, I'm with you. It's about what's best for the individual, and I think sometimes people miss the empathy piece. Maybe they haven't experienced true suffering, or physical or emotional, or seen someone or known a family member who have been really ill, but for those of us who have and have been a part of that or experienced it firsthand, it's obviously not fun. And I think we all know that there's a certain point where enough is enough. And with that too, do a lot of the patients who use the medication, from your experience and from what you have observed, do they generally have that feeling and just know, like, okay, today is going to be the day? Or maybe some look at the calendar and say, in 2 weeks on this date, I'm going to use the medication, and that'll give me time to, have so-and-so come out or see these people or whatever it might be.
Right. Now, it's variable, mm-hmm. but most commonly it's set a date where my son can come from Michigan, mm-hmm. whatever it might be, and so I want to wait till he's available to be here with me. There are people that say ASAP, and I'm letting everybody know, and hopefully they can be here. If they can't, then I need to do this as soon as possible. So it's variable. The question is it possible to wait too long and then be too sick to be able to self-administer? And I
It's
have
scary
had,
to think about.
right.
Have you seen that or
I
what?
haven't seen it, but I've had concerns. And then I did have a situation wherein someone had asked, and then the judge in Riverside put a temporary, or whatever you call it, stay on the law so that it became overnight illegal to prescribe End of Life Option Act. So I was unable to prescribe for this gentleman, and he hung himself.
Oh, wow.
And I mean, that was,
That's heavy.
well, then the coroner's involved. And
Yeah.
so, anyway.
Yeah, that's
But I mean, and that speaks to why we need this law.
exactly. Yeah. I mean, that's sending a message from that individual as to how much they were hurting, I think.
Right. No, it could have been a much smoother passage, although perhaps it was smooth for him.
Right. Right.
He did it his way.
Yeah. Are there any other major pieces that you would like to share or consider when talking about the idea of death with dignity or the End of Life Option Act? One thing that you mentioned earlier, which I kind of wanted to touch on real quick too, was our animals and how we euthanize or put our animals down. And I often think back to my dog Dora, and she was so sick at the end of her life. She was having like up to 5 seizures a day. Some of them were 5, 6, 8 minutes long. Um, she lost control of her hind legs at the very end. It's like, man, there's no quality of life there. Why would we ever let anybody suffer like that, an animal or a person? And it was the best gift I gave her was a way out of that suffering. It would have been selfish to keep her around.
Right.
And
and they say those dogs will live forever for us.
right, yeah.
So she never begrudged you for keeping her alive, but then she was thankful when you gave her permission to go.
Exactly, and she, I just think that we owe that to ourselves. I think of people in my life. My grandma, she had pretty horrible dementia at the end of her day. She was just very sick physically, mentally, and there's no quality of life at some point.
Right. Well, Compassion and Choices is an organization which, I mean, dementia is a special circumstance because by law those people can't
exactly
take their own lives.
And I think that's important too. You need to have, independence and autonomy and self-determination and such. But at the same time, like, I wonder if there'd ever be an opportunity like where early onset dementia, like, okay, I have this disease. Would someone be able to say, I want this option as the End of Life Option Act, but only once I get to this point? Are you able to prescribe that for?
You can't do the end of life option, but what you can do when you have full competence and you're working to set up your advanced directives, which is, what to do should something happen to me. If, I'm found not breathing, do I go on a breathing machine or CPR? You can set up an advanced directive to say, should I not be able to decide for myself, should I have dementia? Then, for example, don't feed me, don't hydrate me, in which case, over a period of days to weeks, you'll die.
Yeah.
Presently, we keep a lot of people alive with what you and I might regard as poor quality of life. And who's it satisfying? There are families who push to hydrate and feed their elderly parents who are not at all communicative, locked in, whatever it might be. It's not my place as a physician to place my values on them.
Sure.
But I do try to encourage people that I know presently, friends whose, I'm in the age group now where dementia may be around the corner.
Sure.
I'd like to have advanced directives to say, please don't feed me. I mean, I don't want to be a burden if I don't have quality of life.
Sure.
So there is that option. And then on the Compassion and Choices website, they have a lot of resources on how to write those advanced directives.
Good.
So, and they have, various things like, don't feed me if I turn my head away from, the spoon. Don't
Right.
feed me if I appear totally disinterested.
Okay.
So
it's somewhat similar in a way. You can kind of have some of that control. And I'm not saying like, hey, let's go around and, have all these people use this medication. It's nothing like that at all. But
Right.
just for your own, I mean, you get to, with that particular disease, you get to a point where you don't have any recognition of really anything, yourself or anybody. And
right. Well, and in the olden days, before modern medicine and our ability to keep people alive and our state laws that protect care in the nursing homes, and people didn't live long after getting into that circumstance
Right.
where they couldn't care for themselves.
Sure.
But, there are societal mores or whatever it might be that cause people to think we have to care for this person, have to keep them alive as long as they're breathing. But, that's a value judgment.
Yeah. Everyone's got a different perspective, I think.
Well, and everybody's entitled to their values.
Absolutely. Husband, do you have anything? You always seem to have some gems at the end of these little discussions.
I just wanted to ask one question, which is that you were talking about grief, and I was just wondering if like grief experience for families, or like in your experience anyways, is it different for families when they experience like grief regularly versus if they do it with the death with dignity process? Like what is it like for the families afterwards, I guess, if you have any insight like into that?
Well, we spoke to that briefly about our chaplain saying, or bereavement coordinator saying she thought that this should be studied. But my personal observation is that it's easier for these families when it's been discussed in advance. They have their final goodbyes. They know what their loved ones' wishes are. I have been involved where I was at a home one time and ALS patient with a tracheostomy that he is having to suction and feeding tube, whatever, and he just said, "I'm done." And his son came in and said, "I don't approve of this." And I said, "Well, why is that?" He said, "Well, Dad sometimes tells a funny joke." And I said, "Well, let's ask your dad what he wants." I said, "It would be nice if we could achieve some consensus here. It would be important, I think, for your dad to know that you support him in this effort." And, you could see the wheels turning, and he finally came around.
Good.
But it was kind of a trip that,
Sure.
This guy's quality of life was obviously horrible, and he had reached the end. And yet his son was saying he wanted to keep him around because he told a funny joke every now and then. So,
Yeah.
What a trip.
Not the best trade-off there.
right. So anyway, but in a nutshell, I think it should probably be studied, the grieving process following this versus just allowing things to happen naturally. And then there's grief after sudden death, which has been studied, sudden unexpected loss, which is what I experienced.
Yeah.
So.
Yeah, your dad was on the same plane as Stephen Colbert's dad, right?
Mm-hmm.
Yeah.
Yep.
Plane crash, that's about
Right.
as sudden as it gets.
Right. One day they're there and the next day they're gone. And it just kind of helps one put it into perspective on making today count.
Yeah, absolutely.
it's-
The fragility of this life is just, it's hard to describe. That situation right there is the epitome.
Right.
Yeah, that's what I kept thinking about during your guys' discussion. That like the families, whatever happens afterward, is a whole, you know, societal not burden, but like responsibility as well. Maybe introducing this process has actually helped families come, get closer, talk to each other about things they might not necessarily have before because they kind of have a date. And yeah, that
Right.
whole idea is very
As
fascinating.
opposed to somebody being gone and saying, I didn't get to say goodbye.
Yeah, right. Exactly. And yeah, that's a good point, Hosbon. I mean, just from my experience, I've made it a point to talk with each of my individual family members and just talk to them about why I might use this as an option and ask them how they feel. And you know, that's not something we ever would have discussed in this had I not been sick and be out here in California. But I think it gives people a chance to dig deeper and reflect. And I mean, even us, look at us now. We're all here doing this podcast and interviewing you and Dr. Tom. And I think it goes back to, for me, it goes back to the belief of how it's all coming together as we move forward.
Well, and
So,
what I learned from my dad's death is that it's our legacy that carries forward, regardless of what may be there in subatomic particles or the collective consciousness we talked about before. But, I think none of us are going to live forever. And it's our memories then that are going to be held in people's minds and then perhaps shared with the next generation and the one thereafter. But
yeah.
beyond that, do what you can today.
I agree. That's a beautiful perspective, and kind of a nice way to, I think, go out on this pod.
For sure.
The legacy, everyone, as said by Dr. Tom Cummings, along with some really wonderful information and personal experiences. Thank you so much for joining us
Thank you.
today and taking the time out of your busy schedule and just doing what you do to support so many people. It's incredible work, so thank you.
Well, and I want to thank you, Andrew, for having the courage to put it all out there like this. I'm proud to be included.
Absolutely. Thanks, Tom. And thanks for listening, everybody.